Hello, everyone. I'm Dr. Lisa Nijam, the founder of MD Negotiation and Real World Ophthalmology, CEO of Women in Ophthalmology, and the founder and medical director at Warrenville Eye Care and LASIK in Chicago, Illinois. I also do some teaching at the University of Illinois Eye and Ear Infirmary. And I'm really excited to be joined by my dear friend and colleague, Dr. Francis Ma. He needs no introduction. He is internationally known. He's the director of the Cornea Service and co-director of the Refractive Surgery Center at Scripps Clinic in La Jolla, California. Thanks so much for joining me, Francis.
Yeah, no, really excited to be talking about this topic. It's a really exciting time for ocular surface disease, cornea specialists, and just dry eye patients, across the United States. So this is really a pleasure to be talking to you.
It is an exciting time. Actually, we have the spotlight as a cornea specialist. Usually it's those retina guys, but now cornea, the ocular surface is hot stuff. So we're going to discuss some of the new and upcoming developments on treating dry and ocular surface disease, which I think are truly applicable to everyone. It doesn't matter what your specialty is, because if you don't treat the ocular surface, it's going to force you to look at it when your outcomes aren't as good as you want for your patients with any type of surgery, to be honest. So let's dive right in. Francis, what's the average dry eye disease patient in your practice? What's their age? What kind of risk factors? Are there certain jobs that tend to be more associated with dry eye? Who are we talking about here?
Yeah, I think that's an expanding pool of patients. I think traditionally, we would be talking about the postmenopausal, women, but now I think it's almost everybody, right? I mean, I've got kids in my, practice who play video games all day and they're, on computers and digital devices. I've got young people who don't have any eye conditions at all, but they're software engineers and they're on their computer all day. And then we've got older patients who have glaucoma and they're on eye drops, and they've also had LASIK surgery and cataract surgery. So I think in general, it could be anybody. I think that's one of the things that, the really good people who diagnose and manage ocular surface disease like yourself, know. We've always got to have that in the back of our minds that it could be ocular surface disease or dry eye disease that's playing a role in this patient's symptomatology as well as some of the signs. So I think there really isn't a typical age range, but again, historically, we would always talk about the postmenopausal women. I think people that are on their digital devices, computers, reading, that's definitely a risk factor. I think the pandemic really highlighted this fact with people on Netflix and Zooms and the computers and reading and so forth. But I think it could be anybody. In general, we've got to have this top of mind in order to identify these patients and really help these patients out.
I couldn't agree more. I actually experienced dry eye for the first time during the pandemic myself. And it wasn't until I was on literally Zoom calls, I think for 8 hours straight, that at the end, my eyes were burning. It was really difficult. And I said, oh, I've got dry eyes. How did this happen?
It's crazy. It's really crazy. It's it's an experience, right? To finally or unfortunately experience what our patients are experiencing. But it kind of, I think it helps us to discuss with patients these types of symptoms and how to manage these symptoms. And it also, I think, we can empathize with our patients these symptoms. I get dry eye symptoms, especially when I'm operating, and Zooms just like you. So I think we can all empathize with our patients.
Yeah, I definitely know we can relate much more. And I think, as you said, that pool has expanded because we do have so much interaction with digital devices nowadays, much more than we've ever had before, and also much younger than we've ever had before. I mean, school age kids are not. My nieces don't carry books to school. They have laptops. So it's a whole different age. And I think something that we as clinicians need to be aware of. I heard a statistic the other day that the top 10 most commonly prescribed systemic medications in the US cause dry eye as well as a side effect? I mean, I just think with the antihypertensives, with the antidepressants, allergy, there are just so many things that we have that can be contributing to this. So from that, I want to shift to talk about just briefly, what are some of the common unmet needs with traditional OTC dry eye solutions? We know a lot of patients come in having tried artificial tears or other kind of lubricants first, on average 2 to 3 before they reach us. So what do you see with the patients that come in having done that?
You took some of the words right out of my mouth when you started asking the question. Most of the patients that come to see us, that have complaints of dry eyes, have already tried, artificial tears, lubricants, gels, and so forth. I think, the issue with preservatives, we all know about preservatives and how preservatives can cause further damage to the ocular surface, but that's not really, educated very well. I think the other aspect is there are a lot of drops, that are over-the-counter allergy eye drops and, to get the red out eye drops. And patients don't understand the differences. They have symptoms, but they don't understand the differences. So they could, be completely causing more symptoms and exacerbating, the dry eye symptoms with medicamentosa. So I think there's a lot of education that needs to happen. And sometimes patients unknowingly are just exacerbating the situation with preservatives and various different chemicals that are on the surface of the eye. And as you said, most of the times patients have already used, 2 or 3 different drops. And the average patient, I think, just gets the advice to, use an artificial tear when they go to see an eye care specialist. So I think there's a huge unmet need educationally as well as, therapeutically. I think a minority of patients, something like 10% of dry eye patients actually get a prescription, when they see their eye care specialist, and they're just advised to use artificial tears, which, as you said, they've already tried 2 or 3 of them typically.
Yeah, I think that's one of the things that I have substantially changed in my practice in the last several years, as we've been fortunate enough to have more options, prescription options, medication to treat patients with ocular surface and DED. And one of the things that I've changed, one of the things I've done is I have been more assertive about giving prescriptions sooner. I still recommend high quality, hyaluronic acid based, preservative free artificial tears because I think patients still, whatever I give them, they still like having that kind of comfort security blanket of having an artificial tear that they can put on their eye. And I don't blame them. I want them to have something that has data that we know works. But then I have been more willing to give them a prescription drop because they can get the tears on their own. They don't need me for that, but they do need me to give them something that's actually going to treat them and the mechanism of action and break that cycle of inflammation that we know is occurring. So one of the innovations that we mentioned we're going to talk about are the newer cyclosporin formulas. And we now have nanomicellar cyclosporin 0.09%, as well as a water-free cyclosporin 0.1%. Are you using these in your practice? Who do you think are good candidates for these types of drops? Are you use one over the other? Tell us what you think about them.
Yeah, no, I think these are excellent additions to our armamentarium. We know about the history of cyclosporin. There's a long, wide history of using cyclosporin for the ocular surface, and obviously the first FDA-approved drug for dry eye disease was cyclosporin 0.05%. And it was excellent, but it had some downsides, right? As far as the adverse event, we always talk about the burning, and stinging upon installation that, kind of limited some of the use. In addition, as far as efficacy, it was FDA approved primarily for the Schirmer's tests. And as far as some of the other symptoms and other signs, although there were some studies to show that it was excellent to be used in a variety of patients. There wasn't a whole lot of other studies to show the efficacy in terms of symptoms as well as in terms of some of these other signs like keratitis and so forth. So the nanomicellar cyclosporin, the 0.09% was FDA approved. It is also for signs, but they actually have done a couple of really interesting, unique studies. One of the studies, for example, was they kind of went head to head with people that failed the cyclosporin 0.05%. And that was always the big question, right? Is this going to work in patients that failed 0.05%? It's cyclosporin. But they did a study. It was a really unique study with some really good scientists. And they took 124 patients who failed cyclosporin 0.05%, and they started these patients on cyclosporin 0.09%. And they looked at various different things like corneal fluorescein staining, Schirmer's, Sandy, and they showed that actually the patients with the 0.09% did really well and were better, and they preferred the 0.09. I think it was like 70% of the patients preferred the 0.09% over the 0.05%. So I think, that's again, a very unique study that shows that you can use 0.09% in patients that have failed 0.05%. It is much more comfortable. That's what the nanomicellar vehicle is for. It also increases the concentration that you're able to put into the formulas. And so as far as the tolerability, it should improve the tolerability. Efficacy should be improved as well. And then the water-free cyclosporin, which was just recently FDA approved, which is cyclosporin 0.1%, kind of doubles down on that concentration as well as tolerability. And they did show in their phase 3 clinical trials that not only were they able to improve corneal fluorescein staining, but they also had an improvement in the symptoms of eye dryness by week 4. So it does seem to improve the speed of activity and the efficacy, as well as improve the tolerability. So I think you can use these agents in patients who have failed cyclosporin 0.05%, for example. It does improve the tolerability quite a bit. So, for patients, for example, that might have some burning or stinging, for example, if you have inflammation that you want to control, in these patients and you want to use something chronically long term, these are excellent, agents for that. So I think these are nice additions using vehicles as well as increasing the concentration with the unique vehicles.
Yeah, I completely agree. I think the advantage of the newer cyclosporins, and they have slightly different concentrations, different vehicles there, but that allows for a broader swath of patients for it to be potentially effective for. That method of delivery is really important because of as you alluded to, the hydrophobic nature of the cyclosporin itself. And the newer generations of these drops really take that MOA to the next level to be able to deliver it to patients in a way that can be efficacious. I think one of the things that has been really helpful to me has been the newer formulation of steroid to reduce inflammation, particularly in flare-ups for dry eye disease, as well as induction. And so I'm talking about the loteprednol, etabonate 0.25% with the mucus penetrating particles. I found that to be incredibly helpful. I use that actually fairly often because it has excellent safety profile, and it's actually the only steroid that is FDA approved for short-term treatment of dry eye disease. And it got that, as you know, it got that indication because it was able to show rapid improvement in signs and symptoms in a short time period with minimal chance of elevation of pressure. And I've actually used it successfully in glaucoma patients. And it's been really great because you can tell me if I'm wrong, but I think the number one thing that people, especially with pain and discomfort from dry eye, they want to feel better fast.
Yeah. Oh, I completely agree. I think this is, and as you said, it's a great addition because it's something that is going to work quickly. Patients are really going to thank, the providers for using it. It's a short course, so it's not going to be the be all end all for everybody. Some people are going to need something for more chronic treatment, but a lot of people, a couple times a year, two, three times a year, they have a flare up. They use this for a couple of weeks, four times a day, and it gets them feeling better much quicker. They feel like kind of go on with their lives without having a more chronic medication. So I completely agree with you. I think this has been a really good addition to our armamentarium for dry eye disease.
And I like the fact that it's on label. It's possibly the MDJD. It's the JD part that's coming out there. But I think it's really important for clinicians to recognize that you're using it on label to treat dry eye disease. There's data that supports this. There's data that supports that it's fast, efficacious, and safe. And it is a great way, like you said, if there's chronic inflammation or there's need for additional treatment, many dry eye patients can't tolerate some of these other chronic anti-inflammatories when their surface is so hot and so irritated. And so I've been able to start them on loteprednol tabinate 0.25% with MPPs for the first week. And then as they start their second week course, I will fold in one of the anti-inflammatory chronic agents, and that seemed to work really well for my patients and given them the opportunity to use some of the longer term medications that they need with success.
I agree. You can use it a couple different ways, and that's a phenomenal way to get people to kind of buy into your treatment paradigm.
Yeah. We'll touch on a couple others quickly here. Again, it's such an exciting time. This is why cornea is the best. We've got some other agents that have been recently approved for dry eye disease with brand new mechanism of action. There's the varenicline intranasal spray, which works via neurostimulation of the trigeminal nerve. And that's been really exciting for patients who can't or don't want to use any more drops. And then we've also had another one that I use routinely in my practice is the perfluorohexyl which is the first and only medication that has been approved for evaporation, which is the most common cause of dry eye disease. What are your thoughts on these two medications and how do you use them in your clinic?
I think these are great additions. And I think now we're kind of parsing out, various different patient populations, right? It used to be just give, cyclosporin 0.05 to everybody, regardless of what type of dry eyes they have. And now I think we're becoming a little bit more sophisticated, right? So we've got exactly as you said, that perfluorohexyloctane for a little bit more of the dry eyes, but they've got the evaporative component, the MGD. It's been, just like you said, extremely successful at preventing that evaporation. It's very soothing, very comforting. It works very, very quickly. As far as varenicline, again, unique aspect is that these are normal, natural, healthy tears with all of the, thousands of components that are in a normal, natural tear. And so you're kind of, using the body's own natural tears to kind of heal, but also to treat dry eye disease. And again, it's really great for those patients that for some reason can't use eye drops, whether it's makeup or whether it's contact lenses, whether it's some other issue with the drop because they're already using several different types of eye drops. So these are very good, nice additions. And again, I think we're starting to become a little bit more sophisticated in the patient populations that we can use instead of just trying to use one for that round peg for every single opening. Now we've got different specific pegs for the different specific size and shape types of openings. So I think it's a good sign that we're becoming a little bit more sophisticated in our medications and treatments for dry eyes.
You're completely right. What I think the exciting part of ocular surface and dry eye disease and where cornea has moved to is really with this personalized care and identifying the different types of dry eye disease and the causes, and then being more intentional about the prescriptions that we're giving patients to make sure that we are addressing the root cause when possible, as well as the areas of overlap, and doing so in a way that provides our patients relief that is quick, that's safe, and that's efficacious. Even with that, there's still new therapeutics on the horizon. And one that I've been, and I know you've been involved with for a while, and I'm anxiously watching and waiting. The phase 3 data just came out, is AR 15512 TRPM8 receptor agonist. It just met the primary endpoint in the phase 3 COMET trials. Do you want to share with our audience this unique mechanism of action? Again, another unique mechanism of action, which I think is fantastic for our patients to be able to have really different medications that can treat the ocular surface and hopefully provide a wider breath of relief to a wider group of patients of the 38 to 44 million dry eye disease sufferers.
Yeah, you're absolutely right. It's a very unique mechanism of action. We've never had anything like this before. It's actually a very natural, normal reaction. So, if you kind of think about, going out, we're kind of entering into that type of weather. But, if you go outside and it's kind of cool, brisk fall day, and you're blinking and you start tearing, because of the cold air. That would be kind of a simulation of the natural feedback loop that the eye has to help with tearing. That mechanism is kind of a thermoregulation, or similar to that neurostimulation, where you've got this cooling that helps to produce tears. And that's exactly the same mechanism as this TRPM8 receptor agonist. They did have a couple of studies, the COMET studies, that did show the efficacy in terms of creating tears extremely rapidly. They also have good data as far as symptom data as well. So I think a lot of people are anxiously awaiting this because it works so quickly to help not only create tears, but also to relieve dry eye symptoms very rapidly, and using, again, another unique mechanism of action.
I know that fall weather in San Diego must just be like our fall weather in Chicago. And the truth is that dry eye patients exist all across the country, and they do suffer a lot. And it's really so refreshing to see that there are a number of different options that we have for our patients. And I really would encourage our audience to explore these different options in the armamentarium that Francis was referring to, because it's really a shame if you're just prescribing one type of dry eye product at this point, because we do have so many different offerings that we can really tailor to our patients' particular mechanisms of disease and symptoms that they're having to provide them real relief. And if you've ever suffered from dry eye yourself, this is something that is constantly bothering people, that you can make such a huge impact and difference on their quality of life, on their day to day. There's all kinds of data showing the productivity cost and the mental strain and the emotional strain on patients that suffer pain in their eyes from constant dry eye disease. So these things are really exciting to me, and I think that we even have more exciting things coming on the horizon. And so I hope this podcast was educational for all of you, and you've learned something new, and you will go try one of these new dry eye products in your patients. Francis, any closing words?
No, I just really appreciate you inviting me to participate in this podcast. And I really, congratulate everything that you've done. And hopefully our listeners have taken home a couple of little pearls, from this excellent series that you're moderating.
Thank you so much. And thanks again to Dr. Ma for sharing his knowledge and expertise with us, and for this excellent discussion. Thanks to all of you for listening. Please remember to take the post-test and complete the evaluation to receive C credit. And don't forget to tune in for additional episodes within this series. I'm Lisa Nijam, and thank you so much for joining us.